If you put all the TADs all along the midline and they're all standing like this, what's preventing them from doing this or just dragging sideways? You want the force at the bone level to go this way.
Force.
But the force is up here. So the first thing it's going to do is going to do this. The force application of the screw is just way too far from where it needs to be applying.
They claim that the bone remodels.
It doesn't.
And that somehow there's growth occurring.
Yeah, and I had some evil wishers that's claim that, oh, we could show you the evidence. I have not seen the evidence.
No one has seen the evidence.
No evidence. Nope.
It doesn't exist.
It doesn't.
Dr. Lipkin, it's been 2 years since our last interview. It's good to be back with you here at your office.
Pleasure being here.
Pleasure is all mine. Doctor, how many MARPE cases would you say you have under your belt at this point?
Probably close to 1,000.
1,000, and it's...
Beyond 800, I stopped counting.
No kidding, huh?
I mean, if I'm assuming we do at least 4 or 5 a week.
Mm-hmm.
So, 20 times, it's 100 plus a year.
Yeah. And you also teach a course on MARPE.
I do.
And how long have you been teaching that course?
That's for the past 5 years.
One of the original MARPE courses.
One of them, yeah.
Mm-hmm. And in that course, you discuss the use of the Custom MARPE.
Mm-hmm.
And the nature of that Custom MARPE, we could dive a little bit into that. We all know what it is pretty much at this point, though. It was a tremendous improvement upon the off-the-shelf MSE item.
Mm-hmm. And
how many of your 800 to 1,000 cases revolve around the Custom MARPE made by the Partners Dental Studio?
For that, probably around 400 or 500.
Okay, so if anyone is an expert specifically in Custom MARPE, it would probably be you, or you would be one of them.
I'll probably, I don't like calling myself, in any way unique, but definitely one of them. But if you remember, when I started using MSE, I used the laser welder and customized my own MSEs before Custom MARPEs ever came to light.
Right.
So
you've been deep into the world of modifying skeletal expander designs to make them more effective.
Yeah, very deep.
And then, so given your expertise, and given that we haven't spoken in 2 years on camera, all the rage of the past 2 years has been around, or at least the past year, the past 18 months, let's say, has been around the FME appliance, the Facegenics mid-facial expander. You and I haven't had a chance to talk much about that. That appliance is positioned in the market really as a direct challenge to the Custom MARPE, specifically the Partners Custom MARPE. What is your reaction to the hype around the FME and to its design?
Again, they've had some evolution in the rechanges to the appliance itself, right? So, if I say that I'm really familiar with what their latest thing is, I am not. However, I do know of a few cases, a handful, that, let's say, FME did not work. And for me, again, I can't speak because I have not tried it. However, to me, the design of it, the physics behind the appliance, at least visually, has some faults.
Okay.
If I may.
Okay.
So I got this little diagram, and essentially...
Doctor, maybe before we go any further, let me ask you outright. Before you describe too much your thoughts on the FME, do you have any existing relationship with the Partners Dental Studio, a financial relationship or anything that you would like to disclose, prefacing your discussion of other brands?
Absolutely. I have no financial interest in discussing Partners Lab, other than just I'm a customer. Occasionally they do sponsor lunches for my courses, but that's as far as the relationship goes.
And that amounts to providing a catered lunch at your MARPE course?
Yeah, exactly.
Okay.
So no other financial interest.
So you're not a stakeholder. You don't. You're not otherwise incentivized
in no way.
Okay. So your view can be considered totally objective and unbiased.
Absolutely. And if as much as I love my friend Jamil, if there's tomorrow a better lab that comes along that provides a better service, I will use something else.
Jamil is the gentleman.
Yeah.
Got it.
Yeah.
Okay.
But so far, and this is my personal opinion, they're really superb in their manufacturing and customer service.
Great. So your thoughts on the FME?
So my thoughts on FME. When I was using MSE and I started getting cases failed, I was trying to analyze why it's failing. Is it what is it? Is it the placement? Is it the direction of the force? And one of the things that I discovered really early is that if you look at the cross section of the MSE, right? So this is the palate. That's the nose. Now we have a tad here, tad here. The black is the eyelets of the MSE, right? So biggest issue when the MSE failed, right? What happened to that? The tad starts to tip. Any case that you see a failed MSE, the tads are going sideways. And essentially, think of this as a drywall. You put two nails into the drywall and you put a sideways force. It's a tipping force, right? The mechanism, this expansion mechanism is somewhere here. So you have a force on one tad going in this direction, and the same story here. And inevitably, if this distance is too long or this distance is too short, then these starts to tip and the MSE would fail.
Hence the obsession with bicortical engagement. If you could deepen the tad enough and it could capture both sides of the bone sandwich,
exactly,
you were less likely to get tipping.
Yeah. So exactly, you're getting because the cancellous bone inside is paper, right? So if you get the bicortical engagement, you get an engagement in this spot, you get an engagement in this spot, and kind of grabbing it in two spots, so holding it better. But still, if it's too thin, this would tip. Right. So one of the early cases when I did my own customizations, I would try to figure out how can I prevent the tad from tipping, and what I would do, I would add a lateral tad, right, like that, to resist that tipping. I would weld a little extension to it.
Perhaps angled, that, toward the camera. Thank you.
So I would put a lateral tad to prevent the tipping of the MSE tads. So if the case would fail the first time, I would close it. I would either remove it and modify it. And as soon as I added lateral tads, the case would open. And very often, I even have a patient who let me torture him 3 times. He was a 23-year-old, 24, so really should have been easy split. I put a conventional MSE for him first. It failed. I modified and I made a tad MSE for him, but they all were in line like this, and then straight up. All bicortically engaged, everything was perfect. Case failed. And then when he let me torture him 3rd time, I added lateral tads. In the minute I had 6 tads along the midline. He's got really solid bone everywhere. The minute I added the lateral tads, the case split. And it was on more than one occasion. So to me, one of the design faults of the FME is that, again, in the previous cases, don't know what the latest is. But if you put all the tads all along the midline and they're all standing like this,
perpendicular to the jackscrew,
all along the midline, what's preventing them from doing this or just dragging sideways?
Yeah.
And the cases that I have seen with some of the FMEs inserted lately from some of the patients that either came to my office as a second opinion, that was the case. So, and I have a few patients that did not split. And one of the things that I am very adamant about in my practice, I don't want to do anything that's unpredictable. So I've tortured my early patients enough that now I know what I know, how to make it successful. I would say almost 100% of the time.
Right.
So I don't want to have one case that didn't split, or I don't want if I want to do it, I want to do it predictably. And the best way to do it is really custom make where there is bone. Sometimes there's just not enough bone in the middle. You could put 10 TADs along the midline, and you won't have enough support. It's just because it's completely, it's all in line. There's nothing supporting it against the lateral tipping.
Do you think that there's at least merit to the design goal of eliminating arms that connect to the teeth? I think that's really the allure of the FME for a lot of patients, is this hope of getting 100% midline expansion rather than 80-20, 70-30, 50-50, skeletal to dental. I think this a lot of CBCT superimpositions that I've seen with custom MARPEs do show some significant amount of dentoalveolar or dental tipping that is part of the overall intramolar width increase, let's say. And so one could argue that dental arms are always a necessary evil at best. What's your view on potentially designing custom MARPEs in a way that don't involve arms? If you use arms still, why do you use them?
So again, I have not seen what you're describing. I especially with the lateral TADs, I don't find pretty much any tipping whatsoever. So there are certain physical forces that take place even in a custom MARPE, and there are some newer design elements that are preventing those side effects from happening. So if you have a custom MARPE, if you have a palate, right, it's like this, and the forces all along this. If you have like an arch, right? So if this is the palate, teeth is somewhere here. You have you pushing the force and you pushing the palate aside, right? So very often, let's say if you have a deep palate, what I have seen, especially in the early cases where the split is perfect just along the midline, sometimes you may get something like this. Okay, so you might get expansion screw, but now your alveolus, instead of going out this way, goes out this way. So I'd like to have everything expand parallel. And very often the teeth start upper molars starting already in kind of tipped outward position. If that's the case, I will design my plan in order to constrict them after I finish my expansion. But I feel that using the arms to attach to the teeth is still kind of a necessary element, and it would prevent sometimes the MARPE pinching into the tissue, even though the teeth have some mobility. If you don't use any newer elements to secure the MARPE over the TADs, and I could share that with you in just a minute. If you take the MARPE, right, and then just take all the bones, takes all the teeth away, you have a system that could, if you have all along the midline, you have a thing that could easily move up and down, right? If you don't have the teeth, you could easily go in and pinch the tissue. And sometimes you actually get intrusion of the molars with the like, especially with the MSC expansion.
So you're saying that's how much there is of a tendency for the expander body to slide up and down the TADs.
Yeah, if there is nothing limiting it, and I'm sure people who used to use MSC a lot, they will see this in a bunch of cases where after the MSC is sitting in the mouth for a few weeks, months, you'll start seeing the if nothing holds it in place, right? So it's just free floating. It's the tongue pressure keeps pushing it up. And if it's not attached, if it's attached to the molars, it will actually intrude the molars because the whole platform comes up. You will see the TADs starting to stick out of the MSC, and people think, oh, that my TADs are coming out. No, those are not TADs coming out. That's the actual the whole framework gets pushed up into
That happened
the
to my
tissue.
MSE. I had one TAD in particular that was loose after a couple of months.
One, that's a different story.
Okay.
But if you're seeing all four coming out, that's not the TADs that are getting loose. If you have one TAD come out, yeah, that happens.
Mm-hmm.
But if you have all four coming out and they're solid as a rock, that means your whole frame is just getting into the tissue and getting pushed into the tissue. It could get quite far. Mm-hmm. I've seen some MARPEs or MSCs that are really deeply embedded into the tissue. So keeping the teeth in place, at least for early weeks of expansion, I would say to me is important. I have seen cases where with the custom MARPEs, right, when the practitioner took the bends off too early and it started pinching into the tissue. I think the FME has some sort of a security feature where that thing does not slide. I'm assuming. I don't know that for a fact.
I think it might be the locking TAD heads potentially, because assuming the TAD itself doesn't move, just the expander body going up and down the TAD, almost like a hydraulic on a motorcycle or something. The TADs themselves are threaded at the top, and then they thread into the lumen of the expander, potentially to prevent.
Perfect.
But actually, I never heard anyone say, and I've interviewed several people now about the FME, I've never heard anyone say that was one of the purposes of the locking TADs, was to prevent this sliding up and down. So that's news to me.
Yeah, I think that's probably the case. So that's one of the design faults for classic MSC. So if that, and I'm assuming, I think they have that a feature. So that's, somebody was really smart to do that. But still, even though with FME design, even though, let's say, the platform does not slide up and down, there are still just having things along the midline, in my mind, has some physics elements that might be faulty.
Why would they even try to build an appliance that's based solely on the midline? What's the goal of that? Why is there a fetish around midline only expanders?
I don't know. I think it's just the less hardware in the math, less tongue issues, but I don't like compromises when it comes to treatments. So if I'm going to use FME 100 times and it's going to fail on me once, I don't want to use it.
There's also a new iteration of the FME coming out called FME-V, and supposedly it's designed for very high vaulted palates that are very narrow at the middle that you couldn't even fit a midline only expander on. And that expander does have angled TADs that are shaped like the ones you drew. So presumably that would mean that maybe they're realizing that what you're saying is at least, it's been true in some cases, which is why they're redesigning or at least making a second version of the appliance specifically to add those screws, which you're saying you have added to stock appliances in the past. Yeah.
So if that's the case, then they are realizing that there is faults and then they're modifying it to avoid them.
And would you say that for patients with high vaulted palates, the midline only expanders are especially difficult because there's just not the space for them?
As you may remember when you attended my course, I specifically talk about that white lie or white myth about the deep palates, because I was always able to fit 10 millimeter MSC fully all the way in on the palate that was, looked extremely narrow, that visually you can't do it. So there's techniques to fit it. But with there are also other MARPEs, like a stock markets, not stock markets, stock MARPEs that are designed, quote unquote, for deep palate. But the issue becomes, if the longer the distance between the point of engagement in the bone and that distance where the eyelet is, right? If it's a deep palate, they sometimes, let me just take this off so I could redraw it. All right. So you have this is a design of one of the MARPEs that was designed for deep palate. All right. So they had the legs like these very long legs, and the TADs were engaged on the palate, but the screw, the jack screw, was all the way up on top. So this way they could fit it into a really narrow palate. The issue here is the force that is being applied right up here.
Yes.
All right. So if you want the force at the bone level to go, to go this way,
of course,
but the force is up here. Like you're even if you don't, specifically know physics or anything like that, if you apply moment, this is a very, very huge arm. So the first thing it's going to do is going to do this.
Of course.
So the tip. So that's why a lot of times when they do some of the designs for the MARPEs that are designed, quote unquote, for deep palates, the force application of the screw is just way too far from where it needs to be applying. The beautiful part about the custom, right? This is all they create a huge framework that avoids that fault.
You can basically hug the expander to the palate and keep the jack screw close to the palate, so there's no long lever arms.
Exactly, no long lever arms, or even if they have the screw up high, they will add, let's say, another TAD here somewhere, right, with the eyelet somewhere up there. So now instead of the force being applied to this little guy on the bottom, actually there's a huge frame, and then this is pushing right into the middle of it. So now you're pushing like the whole side out from top and bottom, rather than just putting the force on two little TADs on the bottom.
Sure.
So that's why sometimes when I hear, specifically designed for deep palates, the advantage also, disadvantage rather, of any stock appliance, especially if it goes on the midline, or it goes, even if it has a lateral TADs, you can't predict where the bone is. And if you're putting in FME, even if you have some side TADs, unless you looked at the cone beam and you know exactly where the bone is, like you do it with a custom MARPE, with the FME, if you don't have that customization, if you have a paper thin palette, you could put 10 TADs along the midline.
Right.
They will just drag.
So you're saying some patients just have thin bone along the midline, even though generally the bone is thickest at the midline. Generally, is that true?
At the very midline, yes, but overall in palate, no. So if you look at the palate, the biggest bulk of bone is mostly in the front, and in the back it's just paper thin very often. So and that's if a lot of times. I can show you some cases where, especially in the early MSCs, where we put the TADs and, 4, even 6, and nothing tipped, but all 6 just dragged through the bone. Like literally just stayed, we started this way, we got no expansion, but the bone was so thin, it's just dragged through the bone. And you do that, it happens with the TADs too. Like if you use conventional TADs for other anchors, it would just drag through the bone if it's too thin.
Because of course FME does have customization, but my understanding is that customization is limited to the midline. So you do submit a iTero-scan as well as a CBCT. You send it to their lab, and then they place TADs accordingly based on what's best. But presumably they're limited as to where exactly they're putting them, because the appliance to some degree is an off-the-shelf item.
Right.
It's like a modified off-the-shelf item, but not totally customized the way that the custom MARPE is. So I would understand that limitation.
I'm sure if anything that's, you take something that's off the shelf and you have limited ability to customize it to exactly where the bone is, then some things are doomed to fail. That's why, and I'm sure it will probably, especially if the patients are fairly young, and maybe like either prior to 20 or early 20s, or females maybe even 30, this will probably work just great, just fine. And but I don't want to take a chance. For me personally, if I use it on my patients, I'm not going to take a chance.
Do you think even in the era of the popularization of the Piezo surgical assist, that still the midline anchorage is often not enough?
I've seen this on more than one occasion.
Yeah.
Even with the Custom MARPEs. Kid, 22, 23 years old, Custom MARPE, very often just the midline, no lateral TADs, and patient had the Piezo, and it did not split.
Do you think it's even theoretically possible for skeletal expander design to get to a point where the surgical assist becomes obsolete?
I would say it is almost obsolete. However, there are cases where you would still use it. For example, patients that there are some bones that are just ridiculously weird, like they're super thin, or some weird anatomy where there's just very little place to put the screws. There's not enough bone to support the MARPE, or very, very thin. Maybe some prior asymmetries, prior surgical involvements, something that has increased risk for for potential problems, then I would certainly say those cases either would benefit from the dome procedure right from the start, or at least every single case that I do, I always say, listen, I haven't had any failures, but you could be the first one.
So even though you suggested a few moments ago that surgical assist could approach obsolescence in many cases, you're still using it quite liberally?
I haven't used it at all in the past 2 years.
I'm talking even Piezo midline assist.
Oh, no. Piezo I do routinely.
Okay, so sure. So when I said surgical assist a minute ago, you thought I was saying the dome, the full on.
Yeah.
Lefort cuts.
Yes.
Pterygo plate cuts.
To me, when they say surgically assist, I don't think of Piezo as a surgical assist.
Okay. Will we ever get to a point in MARPE design where the Piezo assist becomes obsolete?
I don't think so.
You think that there's just a limit as to the strength of the metal and its relationship to the bone and the volume that exists inside human palates, that it's always going to be advantageous to weaken the resistance of the palate? So
let me give you an example. I was just doing in my course just a week ago. When you're using a Custom MARPE, the body does not know where to split. It splits at the weakest point. When my son was 5 years old, he was taking Taekwondo lessons, and they had a board breaking exercise for 5-year-olds. It's a pretty thick board, right? So, but if you're adult, it's hard to break, but especially for the 5-year-olds. So what they do is they do a pre-cut right in the middle of that board, and that creates a weak point on the board. So when the 5-year-old hits it, at that point, that's where it breaks. Right. So I had one patient of my own where there was like a little bit of a perfect storm where the MARPE design was not it was okay, but in retrospect, I should have had something slightly different, and the cut maybe was not deep enough. We could all analyze it any further, but the point is, the maxilla split not at the midline, but at its weakest point.
Which was where?
Which was actually between the lateral and central, and at the molar. At the molar. So essentially had a little bit of a maxillary break, right? So the point is the maxilla, when it splits, it will split where it's the weakest, and cases that I've seen from other practitioners where you especially have asymmetric expansions. That's what happens. It splits at the weakest point. So when you do the Piezo, it creates that weak point where it quote unquote assures you that it will split in the midline and not somewhere else.
Mm-hmm. Yeah. regarding some merits of the FME and how maybe custom MARPE design is changing alongside it, perhaps even in response to it. Are you intrigued, or do you respect at least some of the features of the FME, such as the locking tads?
Oh, absolutely. I didn't say it's like everything has its place.
Is partners considering introducing something like locking tad heads, threaded tad heads?
No idea, but great idea.
How about the two-piece design of the FME, where you have a chassis that's bolted to the palate, and then you have the body that goes over the chassis so that you can switch out the expander itself without having to remove the tads?
Well, we could do that with a custom. And I've done that on more than one occasion, where we have a swappable design where we could expand to some point. Then when it's max out, let's say it's a really narrow palate, max it out on a smaller expander, take it out, put a bigger expander without removing the tads.
Oh, I didn't realize that that was an option with Custom MARPE.
Yeah, that's one of the options. And on a few occasions, we can actually remove the MARPE. So let's say you reached a certain amount of expansion. I had actually two cases where on one, the actual screw, the jack screw, broke right in the middle of expansion. So I cut it out. We scanned the case, and we created an overlay that, completed the expansion. So that, or, it could have been a bigger screw if in retrospect. So it's really very, very easily accomplished with a custom MARPE. And in another case, just happened, I had a patient from California where she had a crown on one tooth, and the MARPE was cemented to the crown. And then during initial expansion, he split fine, but all of a sudden the crown became loose, and he used the Facemask that was attached to the band that was attached to the crown. So now you can't use it anymore. So we created an overlay that was cemented to the existing framework, with the new bands to premolars. And so there's a way to design or redesign or adjust custom MARPE in the process.
And are these refinements a relatively new thing as of since we talked 2 years ago?
Probably. Mm-hmm. Yeah, probably. Another thing I just had it in my mind.
Sure.
So there's other thing that we've created with the partners, particularly. I modestly call them Lipkin Wings, that actually allow you to lock just like the FME does. It's not a threaded, but it's a little technique that allows you to lock the tad to the frame, so there's no sliding of the MARPE on the tad. And
what basically is it?
It's like a little extensions around the eyelet, and you put a steel ligature and you lock the head of the tad so it cannot be pulled out. It's
kind of like not quite a lock washer, but it's something you sort of jam up in there. Yeah, you could
say that.
Interesting. Well, you've coined it. It's the Lipkin Wings.
That's right.
So another feature of the FME, which is getting a lot of attention, is the fact that Facegenics takes over some of the cephalometric analysis work to help with appliance orientation, to help minimize the asymmetry problem that has sort of plagued the MARPE world over the past few years. Basically, they decide how the appliance is going to be oriented, and in making that decision, they do a whole cephalometric workup like a jaw surgeon would, where they align the CBCT and they look at various facial landmarks, and they decide, okay, the jack screw is best placed here because we know it's just going to blast out left-right with respect to itself. And if it goes left-right from here, we know that the skull is going to move like this, and presumably asymmetries will be mitigated or perhaps eliminated, or maybe even reversed. Reversed might be pushing it.
Pushing it.
Yeah, definitely. That's a gold standard that I think is still like a platonic form out in the ether somewhere, maybe someday. But how do you do that part of the MARPE design where you decide based on cephalometric workup how to orient the jack screw to mitigate asymmetry? We've talked about this before, but it's been 2 years. What are your updates on the asymmetry problem?
So my update is exactly the same it was 2 years ago.
Okay.
Every single asymmetry case that I've seen was a misdiagnosing of initial asymmetry, was improper placement or orientation of the screw, and when the lab placed it incorrectly, or a practitioner did not see the issue. So
you just described a few different things, and let me parse them out. So you're describing improper orientation. Is that the doctor's decision, or is that the lab's decision?
It should be a doctor's decision.
But then you also described a quality control issue where the lab doesn't actually construct the appliance according to the doctor's plan. Maybe the doctor got it right, but the lab missed it by a fraction of a millimeter.
Yep.
Or actually, probably we're talking about degrees.
Usually.
And so, and then the doctor then errs by not doing a QC prior to placement of the appliance.
Yeah. Correct. So essentially, as an orthodontist, I should be diagnosing the asymmetry. That's part of every single workup. And if you ask me how many asymmetric splits I've had, I'll tell you it's 0. Every single case gets brainwashed through tiniest of possibilities, and using cone beam, it's impossible not to see it.
So what's that workflow look like? You're on the computer, you have the CBCT, you also have a dental scan, an iTero scan.
Oh, sure.
And then what do you actually do with those images to perform the analysis?
When you get a cone beam, right? The first step is orienting the cone beam properly in the software, right? Because a lot of times patients, when the image is taken in the cone beam, they could sit like this, all right? They could sit like, every which way. And I've seen if I've seen cone beams that have been, let's say, posted, and it's like, look at the asymmetry, but it's just the guy's tipping the head out, and they're showing as if it's like a major asymmetry, which it wasn't. Right. So orientation. So if the patient's taking a cone beam like this, we need to straighten the cone beam straight, right? So to get all the lines, you could look at it from the top, from the back, to make sure that all the skeletal structures are oriented straight up and down.
And so, for example, you're looking at what, the skull base?
The simplest thing is to try to superimpose the orbits on each other. Most people have orbits symmetric, with a few exceptions.
Symmetric or asymmetric?
No, symmetric.
Symmetric orbits.
Yeah, the orbits usually, most of the time, not always, but most of the time. If you have, like, if you look at some of the structures, like in the cone beam, if you're looking at the volume and you increase the visibility of the bone, you could see that, certain lines, like a nasal spine or some, skull base structures that are allow you to position it properly. So to start, for example, my first step is if I'm looking at a skull and things look fairly symmetric, I'll superimpose the orbits on each other. Then I look from the front and I see if that looks symmetric. Then that's my start. Okay. Then now my skull at least oriented properly.
So you orient the orbits, and then you draw a line through them that's flat with the earth.
You could say that. Yeah.
Okay.
Yeah. And then if the orbits are not symmetric, there are still certain features that clearly could see the orientation of the skull, and then you could put a few lines along the way onto the image, or like a ruler, to make sure that yes, this looks symmetric. The skull itself, right? And then what you do is you have features in various software where you could slice the skull from front to back, right? So you take the skull and then you take a feature, and you basically create a plane right through the first molars, for example, right? And then you could put another line there between either let's say lingual cusps of the molars, or lingual pits of the first molars, or necks, or whatever it is, and then just connect them with the line. And then if that line is if you say you put the line, let's say suborbital line, right? Or sometimes people call it interpupillary line, and that's parallel to the floor, and your occlusal plane, which is the line connecting those two molars, is parallel to the floor, then that case should, is fairly symmetric. If one molar is, and typically the labs will make the screw parallel to the occlusal plane, right? Because majority of the patients have that occlusal plane and suborbital plane a parallel, or the occlusal plane is perpendicular to the skeletal plane, right? But my job as an orthodontist is diagnose it when it's not. Very often the palatal plane will be canted.
Even if the occlusal plane is flat?
Even if the occlusal plane is flat and parallel, let's call it parallel to the floor. So one occlusal plane parallel to the floor, assuming skull is oriented properly, right? So majority of the labs will do the MARPE placement is parallel to the floor, right? But occlusal plane could be canted, and my job as an orthodontist is to see that, even if it's off by a fraction of a millimeter, it's probably not going to be creating a problem.
Unless you do a 15 millimeter expansion or something, then it becomes more significant.
And essentially, in this little diagram, I'm missing this half. But
he was a boxer.
Yeah, he was a boxer. Yes, he lost. But essentially, so what I drew here is a MARPE that's has been installed at an angle. Right. So what ends up happening why asymmetric expansions happen? If you visualize the force that's going up this way, right? You've got cheekbone, you've got the orbital bone, you've got the frontal bone, you got a temporal bone, and all that massive bones resisting this.
You have a rock wall.
Yeah. Exactly. What's resisting this? Nothing.
Yeah.
So this part will go out much faster than the one that's against the wall.
And will it also come forward? Sometimes.
I've seen in my very, 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 very early cases, like one at the first dozen, I accidentally, at that time I didn't make my own MSCs. I sent them to the lab, and the lab had it rotated. If this was a palatal plane, it was, the MARPE was rotated like this. And inevitably, two parts of the palate went this way. Obviously, the one that had least resistance went out forward. So the screw orientation, the jackscrew orientation, has to be absolutely. So if we call it this skeletal midline, it has to be absolutely perfectly perpendicular to that skeletal midline. And then not only in this direction, but if we have an arch, it has to be perpendicular to that, let's say, palatal line.
Right. Help me understand, though. Let's say the occlusal plane, meaning that the teeth surfaces, are parallel to the earth. They're symmetric. But the skeletal arch is asymmetric, meaning that somehow over the patient's life, the teeth have somehow compensated to be flat, even though the bone itself is angled. So are you saying you want to align the MARPE jackscrew with the occlusal plane in that case?
Yes.
But what about potential midfacial asymmetries that can form as a result of taking an existing maxillary asymmetry and sort of magnifying it, even though the teeth remain flat? Wouldn't there still be some evidence of asymmetry in the cheekbones?
Microscopic. There are people who have different slight discrepancies in the cheekbones. One is slightly bigger, one is slightly smaller. As long as you're pushing it parallel equal forces, it doesn't matter. You could if you have existing asymmetry in that regard, where let's say this is smaller, this is bigger, and you do the split, this will still be bigger and this will still be smaller, right? You can't orient the MARPE and change that in any way. So you'll exacerbate some of the existing asymmetries, but it would still, the split itself would still be even.
Yeah. So the goal as a practitioner is not, if you have a symmetric occlusal plane but an asymmetric palate, to sort of create, to align the teeth according to the asymmetric palate and then try to expand the palate out of the asymmetry. You don't do that.
You don't need to.
Yeah, right.
Yeah, you need to create an even maxillary split this way. Even if the palate is canted, it would still, I mean, it's irrelevant, because that whole, so it's like you have an arch, and maybe this part is slightly shorter than this, but at the occlusal plane it's still equal, so it will just split like this, and it will still remain this way, but your palatal, the occlusal plane still remains intact, and you're not going to get into symmetry.
What about in the case of a huge expansion, like a 1 centimeter plus expansion? Couldn't something like that become noticeable at that level of expansion? And is that why, Dr. Ting said a couple years ago that he likes the 4 to 6 millimeter mark in order to just keep the volume turned down on things to minimize fallout from that sort of thing? At what point what point does the magnitude of the expansion become so much that any asymmetry becomes visible?
Quite honestly, I'm not sure. I don't think I've ever had 15 millimeter expansions.
What is your sweet spot generally? I know you can't say, a number that's every time, but...
I would say majority of the patients would be probably around, 8 to 10, sometimes less, extremely rarely more.
Yeah. Extremely
rarely. However, even if the palate itself has some sort of a canting, it's not really a cant per se. It's usually just like a thickness difference. So, but overall structure is still symmetric. Yeah. It's like some part of, let's say you have a house, and there is 2 floors in this half of the house, and there's 3 floors in this part of the house. So they're if we dissect them, they're not symmetric, but overall the walls and that whole part is fairly symmetric.
Right.
So in those cases, you don't have any issues for the splits being even.
Understood. And maybe you've already answered this, but I didn't catch it. Who is responsible for orienting the screw according to the occlusal plane? Is it the lab or is it the dentist?
It should always be the dentist.
Okay. So
if the dentist, so the lab, when I do my cases with the partner's lab, they will ask me, that's always like, it's their standard question. How do you want jack screw to be oriented? Occlusal plane, parallel to the floor, rotationals, and whatever else. So it's always my in my mind, it's a practitioner's should be the one deciding it.
Let's say you have a brand new orthodontist who's doing their first 20 MARPE cases, let's say. If they screw up the orientation of the appliance, maybe because they haven't taken a course like yours, and they don't understand the importance of orientation and the risk associated with getting that wrong, which I would say was probably the norm back in 2019, 2020, before these asymmetry cases came out and people saw it. Would the lab catch a mistake by the dentist and then correct them?
No. The lab is, technicians. They don't have any dental education. They learn how to solder and weld.
Right.
And then in my, let's say the early cases when I just used the MSC, before I customized it, just when I started using it, I would just place it on the model and tell the lab, okay, this is where I want it. And they just had to solder it for me.
Understood.
And that's really all. They didn't know any better than I did at that point. A lot of stuff came on into light later, and I actually just ended up being lucky just by the hunch getting things into the right places. And I analyzed it later, what worked, what didn't.
Well, now we know why on the DAT they have the spatial awareness, spatial recognition part of the exam, because those skills are useful for dentists.
Yeah, technically.
Then do you think it's a problem, or is there a phenomenon happening out there potentially where you have green dentists who are sort of screwing up appliance orientation and it's causing problems. And how do we prevent that? How do we standardize the field in a way that this jackscrew orientation problem becomes less and less frequent?
I don't think you could standardize it unless you have practitioner being aware of it. So for a lot of times when I get called by my past students or people who take my course, I initially take them by the hand, help them design it, but essentially, eventually, they do it themselves.
Mm-hmm.
But that's what makes me a doctor, right? And because if we standardize it and the lab could do it, who needs the doctor, right? So anyone could order the appliance, stick it in, and here we go.
Yeah. It just goes to show how important it is for anyone even thinking about treating patients with MARPE to take a course like yours.
Yeah, well, there's quite a few. My friends Richard Ting, Dr. Evans, Audrey Yoon, Jerry Manuel, and we all have our differences and similarities in a way. We all teach little different techniques. We do things quite, differently. And ideally, if someone who really wants to do it well, I would recommend taking not just one, but a few.
Yeah. You did mention earlier that the palate will split at the point of least resistance.
Mm-hmm.
So I wanted to ask you about patients that have had jaw surgery that now want MARPE.
Mm-hmm.
What challenges does that pose to the expansion process? Some thoughts that come to mind for me are, was it a one-piece Lefort? Was it a segmental Lefort?
Mm-hmm.
What's the state of the union? Because not every
Absolutely.
surgeon grafts as well as another.
Mm-hmm.
So I can see many potential weak points in a post-surgery palate.
Absolutely.
What's been your experience trying to expand jaw surgery patients after they've had surgery?
Have done 4 post-surgical cases. And in each one of them, one of the biggest thing is you really shouldn't do it. But if you do it, you should be aware that that's a possibility. So 3 expanded uneventfully, no issues. I have 2 cases that been actually literally been blessed. I didn't have any more than that. But essentially I have 2 cases that one went a little bit south for the reason I've already mentioned. Possibility that we all occasionally not the greatest of the judgments, right? The design wasn't the best design, the placement, something just didn't quite got together. So one of those fluky things, right? So everything worked out well. Cases, then we're going to redo it with a dome procedure. That was one. One other case, so one of those post-surgical cases where the maxilla split exactly where I said it splits along the weakest points. So it's literally just half of the. So it's the upper. It broke. The suture broke right here at the orbit, and it split right in the middle. But this whole side just went out, right? With this side being completely intact. So,
and how did the surgery contribute to that specific weak point being created?
The surgery created those weak points. So that's actually the patient was so happy with the expansion that because this is easy fix. If you catch it on time, all you have to do is close it back, and it's easily reversible. She was so happy with the expansion, she did not want to reverse it because she's going to do surgical revision anyway. So wasn't a huge issue. However, the point still remains the same. You have a weak point, it will split where it has the least resistance.
Do the multi-piece Lefort surgeries, have you ever done one of those, a MARPE?
Yeah, so I've done 4, and one of them had the complete asymmetry.
So does when you dice the palate up like a pizza pie,
mm-hmm.
does the MARPE tend to break the palate along one of the cuts of the segmental, or not necessarily?
Not necessarily.
Do the surgical plates, if they're still in place, pose any challenge to the expansion?
I thought it would. It didn't.
were the plates in the case that you did, were they like big, robust, custom titanium plates, or were they just regular plates?
In this particular one that didn't went asymmetric, she had no plates. It was removed.
Plates were removed. Would you anticipate that because not all surgical plates are the same?
No, absolutely not.
From what I've seen, you have like the Dr. Gunson plates, which are pretty minimalist.
Mm-hmm.
He's bending them on site. Then you have the Dr. Alfie plates, which on the maxilla, it's one contiguous plate that's significantly more robust than Dr. Gunson's plate. And then you have Dr. Bell's plates, which are like on another level, like super robust. Lots of tads and screws, and then lots of plates.
I think Guts has pretty, lots of plates.
What's that?
Gunson uses extra plates.
Mm-hmm. So could you ever anticipate plates being so robust that they would interfere with the expander's action going left-right? Or are those plates no match for the force of the MARPE?
I don't think it's either. I think what happens is when you get the expansion, right? If you look at the skull, you get a maxilla and zygomatic bones. So you inevitably, this whole midface starts coming sideways. So you get a little bit of wider face. So typically the plates are holding, zygoma to the maxilla, that's like a very typical surgical setup. So because you're getting maxilla and zygomas going sideways, they're not in the way.
Mm-hmm.
Like if you wanted to do a protraction, even if it's that, it would still, you get a whole midface coming forward.
Yeah. I wonder though because Dr. Alfie's plate, for example, is connected across, even at the midline.
I have not seen his plates, so I really can't comment.
I'll put an image of it up, but yeah, it's connected across here, so I wonder if that would prevent...
If that's the case, for sure, it will prevent it.
Interesting. You were just talking about protraction and about some of the non-pure left-right movements that can occur with MARPE. Mm-hmm. For example, the palate coming forward. I want to ask you about that in a minute, but first I want to ask you about this phenomenon of MARPE causing the midface to drop a bit.
Mm-hmm.
Have you seen that?
I'm not sure. What do you mean by drop?
So this idea that all of the resistance or all of the connection of the palate to the cranium is posterior and superior, back and up, so that whenever you split the palate, there's a tendency for the palate not only to go left-right, but also away from its attachments, so forward and down.
Yes, but it's microscopic. So, especially, even if we do a children, right, in a 6-7-year-old, if you use a conventional palate expander, there is a little bit of a forward down displacement. Down displacement is really irrelevant because a lot of those patients have pretty high vaulted palates, so you have to just intrude the molars and you negate it, that down displacement. It's a piece of cake. It's forward movement, usually desirable because you end up improving in posterior airway, pharyngeal airway, and especially if you have like an underbite cases where you want to bring the maxilla more forward, then that's actually, you want that happening. Is the drop effect significant enough that you would consider pre-existing vertical maxillary excess a disqualifier for a patient seeking MARPE? For example, a patient with a gummy smile that had a very much a sort of melted down not at all.
Face?
Not at all. Because if they have a gummy smile, I'm going to manage that dentally. So I will expand them, and I've done this multiple times where we'll expand it and then use that MARPE as an anchor to intrude the teeth to reduce the gummy smile. So that's a really not a very difficult thing to do.
How does intrusion actually affect a gummy smile? Do you also have to do some cosmetic work where you also remove some gum?
Sometimes, yeah, because when you intrude the teeth, you intrude them back into the bone, and the bone itself remodels, but the gum sometimes stays behind. So you basically kind of intruding the tooth and the bone, but the pockets around between the gum and the tooth increase. So sometimes, in some occasion, you might need a little gingivectomy, but that's usually not a difficult thing to do either.
Yeah, part of another thing I've been learning about over the past year, let's say, is restorative dentistry that can aid MARPE.
Mm-hmm.
So, for example, restorative work to address gumminess, or perhaps even once you widen the bone base, the teeth become relatively small compared to the bone, and then doing some restorative work to make the teeth look bigger, to fill in some of those gaps.
Yeah, but that's sometimes also an orthodontic management of it, right? So you have an arch, and you made it bigger, so now you have a space in the middle, right? There's two ways to close it. You could close it this way, right? So that will end up retracting the front teeth, or you could use the MARPE and just slide the teeth all along the perimeter, the periphery of the upper arch, so without bringing it in. So essentially, you start off with the space here. You shift the teeth in this direction, essentially opening space somewhere else, and then you could use the same MARPE to protract the molars more forward. So essentially, you just moving the teeth all along the arch shape, and there is no, in those cases, if the teeth are normal size, then you don't really need to do any restorative work afterwards. Sometimes if the teeth are small, then it's a different story.
So do you generally bring the teeth forward to close the diastema, or do you generally bring the teeth back to close it? What's the standard?
Based on the case, I don't think there's a standard. So if the patient can afford or needs, let's say after the expansion, the front teeth are too far forward, I'll bring them back. Mm-hmm. If we have a situation where we have initially an underbite and we cannot afford any lingual retraction, then we'll protract everything forward. So it's based on individual case.
Because there has been a fuss out there around some patients saying that they felt that after their expansion that their teeth came backward. And yet the conventional wisdom is that the palate comes forward. So how do we square that circle? I think maybe you've provided one answer to it.
This is exactly right. So the palate came forward, teeth went back. Because palate came forward and it kind of came this way.
Yep.
But the teeth went back this way to close the gap. So they're kind of right. But it's just an orthodontic management.
That's a choice, though, to bring the teeth back. Mm-hmm. It's not a necessity. Choice. It's not like the teeth are falling into the quicksand of the void created
Absolutely
by the split.
No, that's an orthodontic management.
Do you think that most orthodontists have the skill necessary to mesialize or to bring forward the teeth following an expansion? That's more difficult, isn't it?
Well, they should take the courses and know about it.
And that involves relatively complicated orthodontic work of using the expander as an anchor.
It's not that complicated.
What does it basically look like?
It's essentially, I'll show it to you later. Like essentially, it's literally moving teeth. So your molars are attached to the MARPE; they don't move. So if you're using braces, then you put coil springs against those non-movable molars, and you push everything else forward. If that's your choice.
And how do you bring the molars forward later?
Great. So you keep the molars, you brought everything forward. Essentially, you had the diastema. You close the diastema by shifting the teeth this way, and then you created spaces in front of the molars. Then you take the bands off the MARPE. You anchor your premolars to the MARPE, or you use the MARPE to hook up the molars and pull the molars forward. Mm-hmm. So technically, it's not a very difficult thing to do.
It's a common sense thing to do, but I would think that it takes some time, and
you just need to see it once.
And so, have you ever used the appliance to aggressively anteriorize the upper front teeth in a sort of AGA-like way?
Oh, no.
You don't believe in dental anteriorization?
I do not. If the bone allows, sure. But in AGA way, where they just push the teeth out of the bone, that we know what happens there.
Yeah, it's not pretty.
And where it's AGA or even Invisalign, doesn't really matter. You're still pushing teeth out of the bone. As a matter of fact, there are some dental appliances like Alf or Vibus or something like that claim these, or similar to AGA, claim this nonsense that the teeth move, that they expand the palates, and they don't. They really move teeth out of the bone.
Yes, they claim that the bone remodels.
It doesn't.
And that is somehow there's growth occurring.
Yeah, and every time I made this claim that they don't, and I had some, evil wishers that's claim that, we could show you the evidence. I have not seen the evidence.
No one has seen the evidence.
No evidence. Nope.
It doesn't exist.
It doesn't. Yeah.
And so, although the MARPE provides a fantastic sort of kickstand that you could use to interiorize things, it's not advisable, as the alveolar bone just tends not to support that type of dental movement.
You can't randomly just move everything forward. So if you have your bone, your bone is your limit, right? So you can mesialize, right? So meaning move everything along the arch, right? Then you keeping things in the same bone frame, you don't change it, right? You can sometimes push things a little bit forward. If let's say your front teeth are starting very upright and you could tip them out, you're still keeping the alveolars the same. You don't really change it. But if you take the tooth and you just push it all the way forward, you could do that with FOT. You can, because there you can remodel the alveolus, and that, there is evidence that's done. But
within limits?
Yes, with a couple of millimeters, safely. But if you don't have a FOT and you just take that tooth and move it vitally forward, you just blow it right out of the bone.
Yeah. Yeah, you push the roots out of the earth and then they start dying.
That's right.
One thing that I really, I admire many things about you and the way you do orthodontics. One thing I especially admire about how you've done things over the past several years is, because I'm privy to a lot of your treatment plans, because patients in my, patient advocacy consulting work that I do, patients send me plans from doctors all over the world. I probably have 15 or 20 of your plans in my archives.
Cool.
You've been making it clear to MARPE patients for years now that SFOT may be necessary if they go through with MARPE.
Yeah.
It says right on the plan, option 2, MARPE plus SFOT, and then it explains what SFOT is.
Yeah.
I appreciate that transparency, that potentially a whole new surgery would be needed for a patient to go down this path. I do find, though, that patients in other practices get blindsided by the need to do SFOT. Once they're deep down the path of expansion, they realize, I'm out to sea and I have no paddle. Now I need to call the Coast Guard, right? And then they realize, oh crap, now I have this expensive, painful surgery that they need to do just to make occlusion feasible again after their expansion. What are your thoughts on patients being caught off guard by the need to do SFOT in order to complete their MARPE treatment?
I think that's a failure to plan. It's a failure of a practitioner to plan. So essentially, the planning is very easy. It's literally, it is so predictable. Everything can be made so predictable. So let's say, if any of the practitioners out there are listening to this podcast, right? How do you know how much expansion you need and how much can you afford of a lower expansion? Your lower is your limit, right? So many patients start off on the lower arch where the lower teeth are tipped lingually, and you have something that's called curve of Wilson, right? So you could upright that curve of Wilson, and it's sometimes could be substantial.
Like what? 2.5 millimeters per side?
Yeah, 2 to 4, sometimes even 4 to 5
per side.
Per side, yeah.
If the teeth are aggressively tipped in.
Aggressively, even not only that. A lot of times, if you take some software, it's like Invisalign software, for example, right, and you scan it with the cone beam, they will let you simulate this movement, right, the buccal uprighting of the lower molar. There's a small issue with that because the buccal uprighting of the lower molar in the software happens along the root tip. And what essentially happens is they move their molar like this, right? And then if you do that, it goes right through the cortical plate. The reality of it is that doesn't move along the root tip. It tips around the center of a tooth like this. So the tooth actually does not change position buccally, and I could show you the evidence of that on a cone beam. So, there is a little bit of a buccal movement, but minimal enough that it does not create perio problem. And yet this rotation could be 4 or 5 millimeters easily. So without creating a periodontal problem. So essentially, any practitioner who uses any kind of software is as basic as Invisalign software, right? And it's literally a free tool that you could use, because unless you order the case, you don't pay for it, right? So you scan the patient into Invisalign, you take the lower arch and you upright the molars. And then all you got to do is take the upper molar. So essentially, you take these teeth and you create a cross bite, right, or edge-to-edge bite. Then you take the upper molars and you move them buccally, and you see immediately how much displacement you have. Let's say you uprighted this 2-3 millimeters, and you created a edge-to-edge bite, and then you took the upper molar, moved it out buccally out of that position into a more ideal position. You look how much it displaced. Let's say 5 millimeters for the argument's sake. So you need 5 millimeter per side on top. Maximum you could afford is 10 millimeters of expansion in that case. It could be 6. So if I'm telling the patient, okay, and this absolutely must happen every single case that you do. It has to be planned out. If it's not planned out, it's a disservice. So if you plan this out and you tell the patient, okay, I can afford to expand you safely 6 millimeters. If you feel that, if you feel that this provided you with enough breathing improvement, aesthetics, then we don't need SFRT. But if, let's say, and I've had cases where I would tell the patient, I can only expand you 4 safely. And after that, unless we do SFRT, I will not be able to match your upper to the lower. And they should, and then they're aware of it. And then in some cases, and we've gone every which way. So in some cases, we did upper, we started with an upper expansion. We got 4 millimeters or 5 millimeters. And the patient said, oh, I actually just had a patient that texted me yesterday. We've done about 3 millimeters and change. And he said, I feel such an improvement. I think I'm great. I don't want to do, I'm done. Let's line up my front teeth and be done with it. And some patients get 10 millimeters and they say, well, I have really, big mouth and I could afford wider smile. For some patients, 2 millimeters is a lot, and 10 might not be sufficient. So the patient had expanded 10 millimeters, but still had big buccal corridors and definitely could afford a wider expansion, maybe a couple extra millimeters. And you also wanted to have, some more improvements on breathing and sleep. And then for that, we went ahead and did the SFRT on the lower, and then we were able to give them more expansion. But that has to be planned before you start the case.
Yeah, no doubt. It's not a nice surprise to get mid-treatment.
Absolutely. And then planning is the key to no matter what we do.
Do you think that every orthodontist doing lots of MARPE should have a good periodontal partner for an SFOT referral?
Yeah.
Is that a key partnership?
Absolutely.
Is that similar to the jaw surgeon partnership, where it's important to have someone that you collaborate with and communicate with?
I have both surgeon. I have surgeon trained SFOT and a periodontist that's trained into SFOT. So if the case does not involve too much of a perio, then I could send him to surgeon. If the patient needs like a little bit of a finesse, then it's a periodontist.
You agree that the periodontist is the sort of higher end option when it comes to SFOT, since it's really in their wheelhouse?
Yeah, but I don't want to offend the surgeons.
No, of course, God forbid. We all know the difference between jaw surgeons and God, right?
Yes. God knows he's not an oral surgeon.
That's right. And who is your SFOT referral? There's not many of them out there that can be really trusted. Who's yours?
No. One is the one I sent you to, is Dr. Rabinowitz.
Yes.
Which we've had quite a few cases and have a really great success. And I have another one, a little South Jersey. She's fairly new. She's newer to SFOT world, but she's done the certification course, and she's just a really good periodontist, Dr. Ann Charniak. I have a local guy, but sometimes his bedside manners are really crap. So
yeah, no, and it's never fun to hear back from a patient about that.
No.
No, Dr. Rabinowitz is great. I love him a lot. He's been nothing but good to me over the years. He's done 3 procedures on me now to try to piece me back together. Mr. Potato Head over here. No, Humpty Dumpty fell off the wall.
That's right.
Broke into a million pieces. No, you've been really instrumental in putting me back together, Doctor, and I just want to express my gratitude for that.
It's a pleasure and an honor.
I think if anyone watching this video, go back to a video from, say, 2021 or 2020 and take a look at me and what I looked like. And if you wonder how I went from that to this, the answer is Dr. Lipkin.
Well, thank you.
So, and thank you. I remember, it's a really traumatic memory of mine. I went to my cousin's wedding in Florida in 2019, end of 2019, and I was just a wreck. I mean, asymmetry and nasty diastemas and gaps from tooth-borne expanders. And my uncle looked at me. I hadn't seen him in a few years, and he said to me, he pulled me aside. He said, "I don't know what the hell happened to you, but you have to fix it. This is unacceptable. You can't present to people like this. It's really weird." And that hit me like a ton of bricks, and I knew I needed help. And all these years later, I think I'm presentable again. So, thank you.
It's a pleasure.
Let's talk about protraction. This to me is also a big gray area when it comes to MARPE. Dr. Manueli played devil's advocate and said, in MARPE plus protraction, aka face mask cases, it's not clear that the face mask is actually doing anything. The MARPE itself brings the palate forward. So it's possible, logically speaking, that in these small class 3 corrections that we're seeing with MARPE plus face mask, that the face mask is having a negligible influence. What are your thoughts?
Disagree. 100%.
Please elaborate.
I've done enough to see the difference. So I've done plenty of cases in class 3s that remain class 3s without the face mask. I've done enough with face mask that it made substantial difference. Just analyzing the pre and post records. So that's basically the case. It's definitely provides enough force for protraction. The degree of protraction could vary. And then there is a definitely little bit of a forward displacement with just MARPE alone. No one disputes that. But I think let's say if we just did a pure MARPE and maxilla, there's actually a research on that. Not with MARPEs, but with conventional expanders. But, with the MARPE, I would say, and this is purely guess. So with the MARPE, if we just use MARPE alone, the maxilla will come forward a millimeter. If we use the face mask, it might come forward 3 to 5. So I don't think I could get maxilla forward 5 millimeters without the face mask. So a perfect example. One kid, mild underbite, class 3 MARPE, didn't use face mask at all, just refused. We actually had to put some instead. So he agreed to wear class 3 elastics. And in order to avoid any kind of negative effect on his lower front teeth, we put TADs on the lower. So
equivalent to bollard plates?
Yeah, equivalent to bollard plates.
All a bollard plate is anchorage at the front of the mandible. Yeah,
exactly.
To avoid dental anchorage.
Yeah, exactly. So when he did not fit, without that, there was no forward displacement. He expanded, but obviously there was no movement forward. I had another patient, actually in the treatment right now, that he started with the MARPE and a face mask, and he just did not use a face mask. And then I keep seeing him, he keeps going back and forth to keep the maxilla loose. Nothing changes. So he's, 3, 4, 6 months later, nice expansion, nothing changes front to back. So I said, you know what? We knew the surgery was a possibility. You're going to go with the surgery.
The MMA surgery.
MMA surgery, or at least maxillary advancement.
Uh-huh.
And then, we started closing the spaces. We started finishing them up. And then one day he says, to be honest with you, I didn't wear my face mask. So, and I really don't want a surgery.
He must have done some research.
Whatever. So he was just blunt honest. Like when he was in the first time, he said, "Oh yeah, I'll wear it. Well, nothing's changing. So, and I told him, okay, not working. And then he admitted it that, you know what, I didn't wear it. I told you I wore it. I didn't wear it, but I don't want a surgery. Can we try this again? Put new MARPE. Now he's wearing a face mask and he's changing forward. Mm-hmm. So that's my evidence to answer that question, where a MARPE alone works or not.
Great. And do you still hold the position that face mask and MARPE is only appropriate for Class 3 patients?
Well, it's sometimes there are patients who are in Class 1, but they have like a Class 3 tendencies. So, for example, their teeth look like they're, let's say, they're still kind of Class 3-ish, right? So let's say the upper front teeth is slightly flared and the lower teeth is slightly angled back, or the lower teeth could be normal, but the front teeth are flared out. So, using protraction this way and then uprighting the teeth would certainly be in that treatment plan. The only contraindication to protraction would be a Class 2 case, because you already have lower jaw that's smaller. Now you're just making that discrepancy way worse.
But even in the case you just described, that is still a kind of skeletal Class 3, where
exactly
you're actually just the only thing that's putting them into a dental Class 1 is flaring.
Yeah, exactly. So it's, yes, in technical terms, it's still Class 3 skeletal.
Are you entertaining patients with skeletal Class 1s that just want to make the maxilla advanced to avoid jaw surgery? Or is that a dubious case in your opinion? For example, what do we do about the mandible?
Well, that's always the question. So let's say in some cases there may be a possibility, and again, you probably have seen cases in my course, or I could show you, where the discrepancy, let's say it's a Class 2 case, right? But the reason it's Class 2 is because the mandible is auto-rotated down and back, and there is actually a vertical discrepancy where the maxilla sits too far down, right? So if you took the teeth and intruded them, the mandible would auto-rotate forward, and now it would auto-rotate into an anterior crossbite, right? So if that's the case, even if it's what we call vertical Class 2, where the mandible is not really deficient, it's just rotated down and back.
Trapped.
It's kind of trapped, yes. So in that case, if you could expand and protract and then intrude, then the mandible would auto-rotate into a more ideal position. So you reduce the vertical dimension that way. So that in that case, it's technically it's a Class 2, but it's not really. It's a vertical Class 2. So you could guide the treatment to fix that using the face mask. But that may be one of the few scenarios where it would be advisable in non-Class 3 case.
That's a excellent nuance. Thank you for shedding light on that. Mm-hmm. How does face mask work in adult males, the toughest of cases? Is face mask limited as to who it will have an effect on? Is it only for women and young men, or is it for all people at this point, depending on the magnitude of the MARPE sort of distraction or, let's say, disturbance of the sutures in the face?
I don't think the age is limit. So I've done a 60-year-old female. I've done 50-year-old male, numerous 30-year-olds, and a couple of 40-year-olds in the works. So as long as you apply the proper protocol and they're really compliant with the face masks and they could tolerate it, because sometimes there are issues with the jaw joints. If they're within the realm of upper displacement that will fix their Class 3, then they're fixable.
And what is that protocol?
The turning should be slow. It should be stretched over a longer period of time. And then there is a back and forth to keep the maxillary sutures loose. Mm-hmm. So I have a couple of 30-year-olds that have gone absolutely tremendous amount forward, where they keep turning back and forth for now almost a year. And they've got significant displacement forward.
So is it about 12 to 18 months, you would say?
I didn't go as far as 18, but definitely at 12.
And how many hours per day?
Like 12 to 14.
So when you're asleep and then as much as possible during the day?
Yeah.
Great. And why even use a face mask when bollard plates are an option?
I think, to me personally, the direction of the vector of the force is different. So face mask, it's more straight out.
Mm-hmm.
A bollard plate is more vertical. So you may get a little bit more of a vertical displacement forward, and maybe less than ideal protraction in that case.
Yeah. And would you go as far as to say that because the MARPE already inclines the midface to drop, that helping it in that direction is not ideal?
Probably. I don't know for sure. Don't have enough evidence.
Are you at all concerned with the bollard plates using the mandible as anchorage for protracting the maxilla is obviously going to have the tendency of jamming the mandible back too? Or is that negligible in practice?
It just has to be, it could be a concern. So because sometimes when you get the maxilla forward and you essentially do get trapped the mandible behind, you had all this freedom, right? And now you protracted it, now you had created an overbite that now your mandible trapped to some degree. In some cases, it could create a TMJ problem. So if it's so that you need to be aware of and know how to deal with it.
What did you mean earlier when you said that if patients can tolerate the potential TMJ effects of face mask?
Or you're loading. You push if you're using conventional face mask, you're pushing on the chin, and inevitably pushing on the joints. And if they're healthy and robust, they could tolerate the force, and then everything is going to go fine. In some occasional cases, especially if the patient already predisposed to TMJ, they could develop TMJ problems. They could develop further disc displacement. They could develop ringing in the ears, or they can actually destroy their condyles.
Mm-hmm. So when it comes to the conventional face mask that's anchored on the forehead and the chin, truly the only difference between that and bollard plates is the vector of the pull. But when it comes to a face mask that's anchored away from the mandible, for example, a bow that's from the sternum to the forehead, or a crane that's neck, then those types of face masks would offer not only the benefit of having the correct vector of pull, but also the benefit of mitigating TMJ fallout?
Absolutely.
Do you ever use those face masks?
Yes.
I know they're hard to get.
Yeah. No, I've used it a few times.
Has Partners considered making a face mask?
Working on it.
Excellent. Facegenics is working on a face mask as well called the FME. Have you heard of it?
No.
People have heard of it. No one's actually seen it. Well, some people have seen it, but only the insiders that are sort of the pilot users for Facegenics. But yeah, we're all curious about what that's going to look like. What about the potential dental tipping effects of face mask? Have you seen that? I've seen it. I've seen a pediatric case where all of the teeth that the face mask was anchored on, now this was a conventional expander, it wasn't a MARPE.
There's your answer right there.
The teeth all flared forward. Actually, he had a tooth gap that was closed by the face mask. Yeah. So there was mesialization of all of the teeth.
Exactly.
Do you see that with face mask and MARPE?
No.
Why not?
You anchor it to the bone. You can't get the teeth forward.
Although
not flared forward.
Right. If they're going to come forward, you're saying it's going to be bodily movement of the tooth?
Well, you have a movement of a maxilla, and the tooth just stays in there.
So because we don't actually attach the protraction device to the unit itself, we build hooks coming off of the unit around the teeth. And so there's an indirect connection to the MARPE.
Right. Even if the MARPE connected to the molar band and the hook is on the molar band, you're still pulling on that frame, not on the tooth itself. So there is no forward movement of that tooth.
And what about retention of face mask gains? How long does a patient need to wear the face mask to retain and stabilize the changes?
I feel that 4-6 months probably would be the minimum.
You mean after the protraction is complete, or do you mean where the face mask?
There has to be some sort of a forward force, whether it's face mask or class 3 elastics, that has to continue with some sort of a forward load in order to solidify the sutures in and around maxilla, so minimize the relapse.
To be clear, so if a patient wears a protraction device for 12 months, are you saying they need an additional 4 months of retention?
No, if they wear that long, probably not.
Okay.
No, if they let's say we got what we needed to get in like the first month or two, I would definitely have them use it for at least another 4-6 months, preferably even more.
Do you have any updated thoughts on mandibular midline surgeries to complement MARPE?
No, still the same. Don't like it.
Remind us why not.
Because when you split the mandible here, unless you split it somewhere else, if you only split it in the midline and you expand the mandible, then you're rotating the condyles in their sockets, and that's going to create TMJ problem.
Yeah. Are you concerned about so let's say you have a very nice parallel mandibular midline distraction rather than one that flares like this. So there's two vectors of torquing the joints, right? There's torquing them this way, and then there's torquing them this way.
Yep.
If the appliance is really low and it causes the mandible to kind of conically expand like that.
Yep.
Are you concerned about both of those?
Yep. Absolutely. I've seen where in some cases where they did the midline osteotomy, but they also did the cuts in the back as well. So it's like they did 1, 2, 3, 4-piece mandible in a way. So even though they expanded the mandible, this part did not change.
The proximal segment remained in place.
The condylar piece remained in place. To me, that looks very tricky, and I don't know. I'm assuming that's probably extremely technique sensitive, but that would the only way that would make sense to do it. But
that's a distraction, or that was just a jaw surgery?
No, just a jaw surgery.
Yeah. Right. Those jaw surgeries are becoming very popular. Dr. David Bell is popularizing that 5 or 6-piece mandibular surgery where he expands at the back but leaves the proximal segment totally neutral. Yeah,
that's the only way it would work.
Yeah, there's a lot of plates involved in that, and a lot of recovery and a lot of moving pieces.
Yeah, too many for my comfort zone.
Well, for a surgery that's weakest point is already how scary it is, and recovery and risk of infection and complication and potential TMJ complications. To add more complexity to that is certainly daunting.
Exactly.
While we're on the subject of MMA surgery, what are the worst outcomes of MMA that you've seen? Are they aesthetic? Are they functional, or both?
Both. Some of them are not aesthetic, some of them non-functional, or some of them neither aesthetic or functional.
Yeah. What are the worst aesthetic outcomes that you see from jaw surgery? I can tell you some of the ones that I see. I see creation of a kind of skeletal class 3 where the bite is okay, but the chin, because there's so much rotation.
Yeah, too much.
They look like this.
Yeah, too much.
And then I see another kind of negative aesthetic outcome where the maxilla is moved forward, not so much via rotation, but just through advancement. And then that causes the upper lip to look really weird.
Yep. You look like a monkey.
Yeah.
Yeah. So I just had another discussion with another patient who is considering jaw surgery. And she says, well, if I don't want to look like a monkey. And to me, the answer is, well, you need to pick the surgeon that has enough experience that could do this properly. Because, I've seen patients, like, let's say, especially Asian patients, where where they typically midface deficient, and when the upper jaw was moved forward with little consideration for the nose, and they look like, the nose went up like this.
Yeah, the pig nose.
Yeah. I've seen that happen. I've seen where the surgeon moved the upper jaw forward, but he moved it like 3 millimeters to the left. And now the entire, so he's basically, he looks like this.
How does that even happen?
This whole thing is off to the left, right? So I've seen that. I've seen where they did the 3-piece maxilla and it created non-union. So the patient has a giant defects between the laterals and canines with like strip gingivites. Like you could see the canine almost to the end of the root. I've seen that. I've seen a case where they did the MMA surgery, but the advancement, I'm not even sure what it was, rotation or advancement. I see the surgical plates and I see the surgery was done. The patient looks somewhat more forward, but the airway looks worse.
How does that happen?
That's a great question. So surgery is, you need to have a right surgeon.
So if you were coaching your own son, God forbid, I don't think your son needs jaw surgery. I've seen him. He's a handsome guy and presumably very healthy. But
thank God.
If you were coaching your own son to choose as a jaw surgeon, how would you help him navigate that process? Would you, and I've seen two options on this, would you try to micromanage the actual movements that the surgeon were to do? For example, would you ask the surgeon to present you with the plan, let's say 2 months in advance, and then you would vet that plan yourself by maybe shopping it around to some other surgeons saying, hey, what do you think about this? Do these movements look appropriate? How do you think this is going to look? How do you think this is going to feel? Or do you just have surgeons in your Rolodex who you can trust to send patients to and know that they're going to be happy on the other end?
I have a few surgeons that I'm happy with, that I've seen, whose work I've seen, right? So I can't really make a judgment of, I've heard great things about this surgeon or that surgeon, but if I've never seen their work, that's all I can say. Oh, I've heard great things about this guy, but I haven't really seen what he does. But whoever, if the person is going for the surgery, the surgeon should be able to plan it out from start to finish. The surgeon should be able to show them a proximal outcome of this, and certain concerns that the patient has should be, listed in bullet points, and then ask the surgeon, what do you do not to prevent the midline being off? What do you do to prevent the post-surgical relapse? What do you do to make sure that I have an increase in the airway, and so on? It just literally have to make a list. Like, sometimes patients come in, and I don't think micromanaging is a good idea. It just annoys the surgeon, and that actually could ruin relationship. Like sometimes with any practitioners, if they start asking questions that might not even be pertinent to the case, right? So, but the key is not to micromanage, but have a list of concerns and asking how these concerns can be addressed, and they need to be comfortable with the surgeon, right? So we all have different personalities, and we all have different ways of doing things. So it's not just for the surgeons, for any doctor for that matter. Like, you need to have some sort of camaraderie relationship that you feel comfortable with that person, that person will take good care of you. If you don't have that trust, then probably not a good idea to start.
Agree or disagree? A jaw surgery is a good one aesthetically if the surgeon is invisible, meaning that a person could present to their mother 6 months after surgery and she would have no idea that they even did surgery. True or false?
Well, that's false. Usually with one of the reasons for doing the surgery is aesthetic improvement. It's not, so there are some changes that need to be significant. Like if somebody is mandibular deficient, if you only move a little bit so you don't see the big difference, then what's the point, right? The whole point of doing jaw deficiency is to correct the deficiency. So that will be a significant facial change. So I think that like minimal, subtle changes, I think that goes for more for plastic surgery. Like, okay, I want a little bit bigger cheekbones, like, maybe little cheek implants. They have to be subtle enough that it, don't jump out at you.
Yeah.
That's a different story. But for the orthodontics, we all go for the improvement, but the final outcome needs to look balanced, right? It needs to look, it needs to be an improvement.
Yeah. Speaking of balance in jaw surgery outcomes, what do you think is the role of malar, infraorbital, and even supraorbital implants in order to allow a relatively normal looking person, like me, for example, who wants a jaw surgery, to make it so that they don't end up looking like a monkey, where the jaws are advanced significantly, but the midface is left behind? Do you think that implants can be important?
Yeah. I know some surgeons put like some type of grafts, say hydroxyapatite grafts or something like that, that will improve the midface look for sure.
Yeah, there's an ongoing debate now about the best kind of implants, whether they're the hydroxyapatite bony implants, like what Dr. Gunson uses, versus what are called PEEK implants, which is essentially a really nice kind of plastic that's custom made to sit over the patient's bone, and it's simply screwed on right on top of the bone. They can put them here. They can put them even here a little bit to help create pronunciation here. Do you have any thought on the ideal way to do implants?
Hydroxyapatite is a natural material, right? It's found in our bones and whatnot. I'm not familiar with the other one, so I don't really have any comment. But in my mind, maybe it's like a little foreign body. So maybe something I wouldn't want to leave in my body for the rest of my life. Well, hydroxyapatite, it's like a typical type of element that's found in my bones. So it's my body is much likely or much less likely to reject it. And because I'm not familiar with that other plastic thing, can't really comment. It's just thinking out loud for now.
Well, the primary issue with the PEEK implants is concern about potential infection, the body rejecting it.
Exactly.
The idea is that if the body doesn't reject it within a certain period of time, let's say 1 or 2 years, that you're probably set for life. But there is a concern that the body does chew it up and spit it out, whereas the bony implants do get, angiogenesis to them. They get integrated if all goes well.
That's the to me, it's more natural way to do it.
Would you be willing to share who your top surgeon of choice is? Like, if you had to have a jaw surgery for yourself or for your son, who would it be? Just no questions asked.
Probably Gunson.
You're not alone.
You know that.
Yeah, you're not alone in feeling that way. I think, especially a lot of the professionals.
Well, it's
Gunson.
I worked with him for more than 20 years. I've known his predecessor, Arnett, which was like spectacular surgeon. And he's still around, obviously, but I don't think he practices anymore. So it's what I've seen. He's just got this aesthetic eye on how to make things look good.
You think Gunson is a surgeon who you would never have to micromanage the movements? You could just trust that he's going to create something that looks good and feels good? I really don't like to micromanage anyone. Yeah. No, it's just not just Gunson. Whoever I work with, I would trust that they're good enough and they would do things properly. I did get burned out a couple of times on that, so obviously not going to use those people anymore. But in general, no, micromanagement is never good. Doctor, what are let's say 1 or 2 things that you're doing now in your practice, especially around MARPE, that you weren't doing 2 years ago when we last talked? Modified some techniques, but I don't think I'm doing too many things differently.
So modified the piezo technique, modified some of the designs, like added some design features to lock the TADs to the frame, but I haven't changed anything drastically.
If I could ask you one technical question about the piezo.
Mm-hmm.
I spoke to a surgeon recently, Dr. Kevin Coppelson, who does a procedure called the Mind.
Mm-hmm.
It's another one of these, maxillofacial surgeon assists like Ease, like two-pen method.
Mm-hmm.
And he said that one thing he does is he separates the septum completely from the floor of the nose as part of his surgical assist to prevent the septum from getting dragged one way or the other attached to the nasal floor during expansion. Mm-hmm. Is that an issue with expansion, that the septum kind of goes for a ride one way or the other, or is it not?
It shouldn't be. Unless your surgical cut was off-center.
So the piezo midline surgical cut, how does that free the septum?
It doesn't.
So then what?
So if let me just draw it for you. So if that's the septum, right, and you get a split here, then this gets dragged this way, this gets dragged this way, and this kind of separates right here, and I have and it's technically just you have like one big void right here. So you have a split here.
Yep.
And then this whole area becomes a mush. This sometimes kind of stretches both ways. Maybe gets slightly wider, but it relatively pretty much I would say always, stays in place. Now, what I have seen, I have a patient that came for a second opinion where they did the piezo, and they, instead of cutting it in the middle, they cut here. So when they
to one side.
So it's just a poor planning. But
what happened in that case?
It got dragged over to the side.
And does that create a nasal breathing obstruction, or does it create something worse?
I don't think it created a nasal breathing obstruction. It's just created improvement in one side and not the other.
Yeah.
So I've seen that happen, but that's probably I don't think that creates a problem per se. It just may not improve it as much.
Could I ask how old you are, doctor?
55.
At this point in your life, in all that you've been through, coming from Russia, starting this incredible dental practice with a specialty in MARPE, what is it that keeps you going, and what are your long-term goals? What is it that you get out of your practice in treating patients at this point? This is the last question, by the way.
Oh, it doesn't matter. I just love when patients look and feel better. So I don't know I think you know my story, right? I became an orthodontic patient. That patient, I looked like Dracula. I was embarrassed of my smile. And then when I got to NYU Dental School, I started my orthodontic treatment, and it changed my life. It made me confident, made me a better person. So I felt that this was such a gift that I felt that I should be able to give it to someone else. And just doing that day in, day out just brings me enormous joy. And when patients are happy, and especially with MARPEs, it puts the practice on a different level, because when I graduated orthodontic residency, I remember one of the older residents said, "Well, you're just a tooth jockey. You just move your teeth around. You're not really a doctor." But addressing TMJ, addressing health along with facial and health improvements and aesthetic improvements, and that just creates, and when patients are super happy about it, and it changed their life for better, that just makes my day.
Well, I'm one of those patients.
Awesome.
So thank you so much for your care, and thank you so much for your time today, doctor.
It's such a pleasure. And now I have a Dr. Lipkin Jr. coming along.
Hey, your son?
Yeah, he's been accepted to orthodontic program.
So he's, when does he begin that?
He begins that in June.
So he is in his 4th year of dental school now?
Yeah, he's graduating in this May.
And where will he be doing his orthodontic residency?
Portland, Oregon.
It's far away.
It's okay. That's why he likes the nature part of it. So
Will he be coming back to this practice?
that's the plan.
Will you need a bigger building at some point?
We'll see.
That's very exciting. Is he interested in skeletal expansion?
Oh, very much. Very much. But this is, I don't know, you could make this part of podcast or not, but this is the most interesting part. And we could spend another hour talking about it. He had, I was blessed with a bright kid, and he's had a lot of interviews, and he only picked 12 to go to because he couldn't make some or whatever. But the point I'm trying to make is, out of 12 programs that he visited for interviews, 9 knew who I was.
Orthodontic programs?
Yeah. Orthodontic programs knew who I was, knew of the MARPE, the work I'm doing, and heard my podcasts or with you, or heard my podcast with a couple other people, saw me lecturing someplace, and they knew who I was, and they knew cases that I presented. Out of those 9, 3 said, and I quote, "What I'm doing is totally unnecessary. There is nothing wrong with extracting teeth. The skeletal expansion is over-treatment, and it's unnecessary."
So they weren't 9 friendlies. They were 9.
No. Well, no. Out of 9 programs, three programs, they disagreed.
Right.
Because
initially when you said it, I thought, oh, these are 9 programs that are going to love this. They love Dr. Lipkin's work, but actually 3 of them disagree with what you do.
That's exactly right. They made it known to Matthew that, look, I saw your dad's presentation. I think what he does is totally unnecessary.
And needless to say, he didn't end up in one of those programs.
He didn't.
And so the program he's going to, what's the reputation there, and what's their perspective on orthodontics?
They're fully open to everything. They open to skeletal expansion. They have a nice craniofacial element to the program. They open to using TADs. They use TADs. They do MARPEs in the program. So he's going to learn good stuff.
That's very exciting, and maybe someday we'll have a second Dr. Lipkin on this show. And you also have a daughter in dental school, don't you?
The second year of dental program, yeah. But she might not be an orthodontist, though. That I'm not sure. So, but she's we have 2 dentists in the pipeline.
Well, I remember you said to me once a long time ago, the best thing is to become a dentist.
No. Plan A was to become a dentist. Plan B was to marry a dentist. Plan C was brainwash my children to become dentists. So check.
You've managed all 3.
All 3.
That's incredible.
Yeah.
Well, it just adds to the legend, Doctor.
I'll take you.
Fantastic. We'll wrap it there. Best of luck to your son.
Thanks so much.
Bye-bye.